Welcome back to the deep dive. Today we are turning our attention to a very small butterfly-shaped organ that sits at the base of your neck. It's one of those things you probably never think about until it starts acting up, and then suddenly it controls your entire life, your energy, your weight, your temperature.
We are talking about the thyroid gland.
Exactly. But we aren't talking about the usual hypo or hyperthyroidism today. We are going to a slightly darker but incredibly important corner of the medical world. We are talking about the C word.
Right, thyroid cancer.
It's a topic that carries a lot of weight. You hear cancer and the immediate reaction is, fear.
Of course. But what's fascinating about thyroid cancer, specifically the text we're covering today, is that the story is often much more optimistic than people expect. It's complex, yes, but it's manageable.
That's the mission today. We are digging into a stack of lecture notes and transcripts from the ENT resident, which is a fantastic resource for deep medical learning, to decode the two main antagonists in this story.
Papillary and follicular carcinoma.
These two make up the vast majority of thyroid cancer cases. And even though they grow in the same organ, sometimes from the very same cell type, they have completely different personalities.
That's a great way to put it. They look different under a microscope, they travel through the body using different highways, and they affect different groups of people.
I love that idea of personalities. We want to move beyond the WebMD symptom list and understand the mechanism. Why does one type like lymph nodes while the other likes bone?
Or why is one linked to, say, nuclear radiation and the other linked to, well, your dinner table salt?
It really is that specific.
It is.
So let's set the stage. How common is this? I mean, if I'm sitting in a room with 100 people, what are the odds?
Well, in the grand scheme of oncology, thyroid cancer is about 1% of all cancers in the body. So it's not the most common, but the incidence has been rising.
Okay.
What really stands out, though, is who it targets.
I saw the stats in the notes. There is a massive gender gap.
Huge. The female-to-male ratio is roughly 3 to 1. And unlike many cancers that are strictly diseases of aging, where you worry about them when you're 70 or 80, thyroid cancer has this unique peak. It often strikes people in their 30s and 40s.
So we are talking about young, active adults, often women, in the prime of their lives.
Exactly. Which adds a whole different layer of anxiety to the diagnosis.
Okay, let's zoom in on the patient experience. You're brushing your teeth, or maybe you're buttoning a shirt, and you feel a lump in your neck. Panic sets in.
Right.
But the source material emphasizes that we shouldn't jump straight to the worst case scenario.
No, absolutely not. The first major fork in the road is benign versus malignant, and the vast majority of thyroid nodules are benign.
Like a follicular adenoma, for instance.
That's the most common one. It's basically just a harmless ball of thyroid cells that decided to grow a bit too much. It's not going to kill you.
But when we do talk about malignancy, we're usually talking about the cells that make the thyroid hormone, the follicular epithelium.
And that gives us our big two. Papillary carcinoma is the heavyweight champion. Depending on which study you read, it's 60 to 80% of all thyroid cancers.
And the runner-up.
That would be follicular carcinoma, which is, usually sitting around 10 to 15%.
And just to clear the deck, there are other types, right?
Yes, there are anaplastic and medullary carcinomas. We aren't going to focus on them today because they are much rarer and behave very, very differently.
Anaplastic is the really bad one, I remember.
Extremely aggressive and scary, yes. But papillary and follicular are what we call differentiated cancers.
Differentiated meaning.
Meaning the cancer cells still look and act somewhat like normal thyroid cells. They haven't gone completely rogue.
And that's a good thing.
That is a huge advantage for us when it comes to treatment, which we'll get to later.
So how does this actually present? I think movies have conditioned us to think cancer looks dramatic, coughing up blood, sudden weight loss, fainting. But the notes describe thyroid cancer as a silent threat.
It is incredibly sneaky. Most patients walk into the clinic feeling perfectly fine. They present with a painless, slow-growing nodule.
Painless.
And here's a paradox that always surprises medical students. If a thyroid nodule is painful, it is actually less likely to be cancer.
That is completely counterintuitive. Pain is the body's alarm system. You think pain equals danger.
In the thyroid, pain usually points to inflammation thyroiditis, or maybe a benign cyst that has bled into itself. Cancer, well, it prefers to be quiet. It wants to grow without drawing attention.
So silence is suspicious. But surely there are red flags. If I have a nodule, what are the signs that make a doctor say, okay, we need to move fast?
Rapid growth is the big one. If someone has had a stable goiter and enlarged thyroid for years, and suddenly it starts doubling in size over a few weeks, that's a major red flag.
Okay.
Also, age is a critical filter.
We mentioned the 30s and 40s peak, but what about the extremes?
Right. If we see a solitary nodule in a child, say under 15, or in an older adult over 60, our suspicion level goes way up.
So a lump in a 12-year-old is much more concerning than a lump in a 35-year-old.
Statistically.
And then we have the real estate problem. The neck is a very crowded neighborhood.
It is packed tight. You got the windpipe, the food pipe, major nerves, major blood vessels. If a tumor gets big enough or starts growing outward, it begins to bully its neighbors.
So you get pressure symptoms.
Exactly. If it pushes back on the esophagus, you get dysphagia, trouble swallowing.
Okay.
If it pushes on the trachea, you get dyspnea, trouble breathing. But the one we really watch out for is the voice.
Hoarseness.
Right. The recurrent laryngeal nerve runs right behind the thyroid. It controls your vocal cords. If a patient comes in with a thyroid nodule and a hoarse, raspy voice, that's an ominous sign.
It means it's not just pushing anymore.
It implies the cancer is invading the nerve itself.
That makes sense. There was one other rare symptom mentioned that sounded like a medical school exam question. Horner syndrome. It's a triad of symptoms, right?
It is. It happens if the tumor presses way back against the sympathetic nerve chain near the spine. You get 3 things on one side of the face. Meiosis, which is a constricted pupil.
Okay.
Pitosis, a drooping eyelid. And anhidrosis, which means you stop sweating on that side of the face.
That is wild. A lump in your neck can stop you from sweating on half your forehead.
Everything is connected. It's rare, but if you see it, you know you're dealing with something invasive.
Okay, let's get into the specific characters. We've identified the lump, we've done the biopsy, and the pathologist is looking into the microscope. Let's start with the star. Papillary thyroid carcinoma, or PTC.
It's the star because it's the most common, but also because it has the most distinct visual flare. And importantly, it is the most common thyroid malignancy in children.
Which sounds terrifying, cancer in kids. But the notes say the prognosis is generally very good.
Excellent, actually. It's very treatable. But to understand PTC, you have to look at the risk factors. The biggest, most established one is radiation.
This always feels like a history lesson.
Well-
We're talking about nuclear fallout.
Fallout is part of it. We saw huge spikes in papillary cancer after Chernobyl and Fukushima. But historically, it was also medical. Decades ago, doctors used to treat benign things like acne or enlarged tonsils with radiation to the neck.
Treating acne with radiation.
It was a different time. We didn't realize back then that the thyroid is essentially a radiation sponge. That exposure sets the stage for genetic breaks later in life.
And then there's the diet factor. This one really surprised me. The source notes say papillary carcinoma is more common in areas with adequate iodine intake.
It's a strange paradox, isn't it? We usually think of nutrients as purely protective. But here, if a population has plenty of iodized salt like here in the US, the thyroid is happy and healthy. But if a cancer does happen to develop, the biology of an iodine-rich thyroid favors the papillary type.
So eating healthy iodized salt shifts you toward the better, more treatable cancer.
In a way, yes, because as we'll see, the alternative is linked to iodine deficiency.
Let's look under the microscope. The description of papillary carcinoma is incredibly vivid. It almost sounds like art criticism.
Pathology is all about pattern recognition. The name papillary comes from the architecture. The tumor forms these papillae, which are little finger-like fronds with a blood vessel core.
Okay.
But the real signature is in the nucleus of the cell.
The orphan Annie eyes. I feel like it's something every medical student memorizes and never forgets.
It's iconic. Normal cell nuclei are dark and dense with DNA, but in papillary carcinoma, the nuclei look cleared out, empty, almost like ground glass. They resemble the blank white eyes of the old comic strip character Little Orphan Annie.
It's such a specific reference.
If a pathologist sees those blank eyes staring back, they know it's papillary. We also see coffee bean nuclei, where the nucleus has a groove down the center, looking exactly like a coffee bean.
And one more Samoma body.
Right. Samoma comes from the Greek word for sand. These are microscopic, calcified, concentric rings, like tiny onions or grains of sand inside type of tumor. They show up in about half of the cases.
So you have this triad: orphan anti-eyes, coffee beans, and sandbodies.
That's the visual fingerprint.
Okay, so that's the ID card. Now, how does it move? If capillary carcinoma decides to leave the thyroid, where does it go?
Capillary carcinoma is a lymphatic lever. It has a strong affinity for the lymph channels, so it spreads to the lymph nodes in the neck very frequently. About 1 in 3 cases will have positive nodes at diagnosis.
Which sounds bad. It's in the nodes, usually the phrase nobody wants to hear.
It sounds scary, but oddly enough, in younger patients with capillary cancer, lymph node spread doesn't severely impact survival. It increases the chance of recurrence, so we have to be more aggressive with surgery, but it rarely kills the patient.
So it's more a local problem.
Pretty much. And it rarely travels far. Distant metastasis to lungs or bones is quite uncommon.
Okay, let's pivot to the antagonist. Follicular thyroid carcinoma.
Yeah.
How is this character different?
First, the casting changes. We aren't seeing this as much in 20-year-olds. This is a cancer of the 50s and 60s. And the background is different. It's more common in regions where people don't get enough iodine.
So inland areas, mountainous regions, places without seafood or iodized salt.
Exactly. When you don't have enough iodine, the thyroid has to work overtime to make hormone. It gets bigger. That the goiter, that constant stimulation and cellular stress lead to different genetic mistakes.
And different genetics means different behavior.
Completely. Papillary is driven by things like BRAF mutations. Follicular is driven by RAS mutations or PAPX, 8-PPAR, gamma fusions. It's a different engine under the hood.
Now, I want to spend a moment on the diagnostic dilemma. The source material makes this sound like a major frustration for doctors. You can't diagnose follicular cancer with a needle biopsy.
This is the great plot twist of thyroid pathology. With papillary, you stick a needle in, you pull out some cells, you see orphan anti-eyes, and you're done. Diagnosis confirmed.
But with follicular.
With follicular, the individual cancer cells look normal. They look almost identical to the benign adenoma cells we talked about earlier.
So if the cells look the same, what makes it cancer?
It's not about who the cells are, it's about what they are doing. The definition of malignancy in follicular carcinoma is invasion. We have to see the tumor physically breaking through its own capsule or eating into blood vessels.
And you can't see a capsule of blood vessels with a tiny needle aspiration.
Bingo! A needle just gives you a slurry of cells, it destroys the architecture. So the pathologist gets the sample and says, well, it's a follicular neoplasm, it might be a benign adenoma, or it might be cancer. I can't tell you until you take it out.
That is wild. You essentially have to undergo surgery just to find out if you needed the surgery.
It's a calculated risk. Usually they remove half the thyroid, a hemithyroidectomy, and send the whole chunk to the lab. The pathologist slices it up and looks at the edges. If they see the tumor breaking out of jail, then it's cancer.
You mentioned it eating into blood vessels. That tells us about how it spreads, doesn't it?
It does. While papillary takes the local roads, the lymphatic follicular carcinoma hops right onto the highway, the bloodstream. This is hematogenous spread.
So it bypasses lymph nodes.
Mostly, yes. Lymph node involvement is rare, maybe 4%. But because it's in the blood, it can travel far and fast. It's much more likely to show up in the bones or the lungs.
So, simpler summary. Papillary is young, lymph-loving, and has distinct orphan anti-eyes. Follicular is older, blood-loving, and hard to diagnose without that.
That's the perfect cheat sheet.
Let's talk about the detective work before the surgery. The toolkit. Ultrasound seems to be the weapon of choice.
Absolutely. Ultrasound is safe, cheap, and gives us great detail. We look for specific bad behaviors in a nodule.
Like what?
We look for hypoechogenicity, meaning the nodule looks darker than the surrounding tissue. We look for microcalcifications, little white specks that represent those sonoma bodies we talked about.
And the shape matters. The notes mentioned taller than wide.
This is a concept that applies to physics. Tissues in the neck run vertically, but they layer horizontally. If a benign thing grows, it usually grows along the path of least resistance. It gets wider, like a pancake.
But cancer doesn't care about boundaries.
It grows against the grain. So if a nodule is taller front to back than it is wide, it suggests it's invading across tissue plane.
That's a really helpful visualization. What about hot and cold nodules? That sounds like a weather report.
That refers to a nuclear medicine scan, or scintigraphy. We give the patient a tiny bit of radioactive tracer. If a nodule is functioning making hormone, it eats up the tracer and lights up on the scan. We call that hot.
And hot is good.
Hot nodules are almost never cancer. They're just overactive workaholics.
Uncold.
Cold means the nodule is lazy. It's just sitting there taking up space, not making hormone. It shows up as a blank spot on the scan.
Huh.
A cold nodule has about a 20% chance of being cancer. So hot is generally good, cold is suspicious.
I also noticed a quirk in the staging system. Usually, stage 4 is terminal, stage 1 is early. But here, age completely rewrites the rule book.
This is unique to differentiated thyroid cancer. Age is the single most important prognostic factor. The cutoff used to be 45, now it's 55. If a patient is under 55, even if they have cancer in their lymph nodes, or even if it has spread to their lungs, they might still be classified as stage 1 or 2.
Wait, even with distant metastasis, that would be stage 4 in almost any other cancer.
It would be. But because young people respond so incredibly well to the treatment we're about to discuss, their survival rates are still fantastic. So the staging system reflects that optimism.
Right. A 25-year-old with lung mets acts very differently than an 80-year-old with lung mets.
Very differently.
So let's get to that treatment. We found it, we staged it, now we fight it. The protocol seems to boil down to 3 words: cut, burn, suppress.
That's the triad. Step 1 is almost always surgery.
How much do they take? Just a lump?
Never just a lump. That's called a lumpectomy, and it's a no-no in thyroid surgery because of the high risk of recurrence and bleeding. It's either half a hemithyroidectomy or the whole thing, a total thyroidectomy.
How hard do they decide?
It's a risk calculation. If it's small, under 1 centimeter, and unifocal, taking half is often enough.
And that saves the patient from needing hormone pills for life.
Exactly. But if it's big, over 4 centimeters, or if there are multiple tumors, or if we know it has spread to nodes, the whole gland has to go.
And if it's in the lymph nodes, they do a neck dissection.
Right. That's a more extensive surgery where they systematically clear out the fatty tissue and lymph nodes from the central or lateral compartments of the neck.
Okay, surgery is done, the thyroid is gone, now comes the burn. This is the radioiodine ablation. This feels like science fiction to me.
It's the original targeted therapy. It relies on a biological quirk. Thyroid cells are the only cells in the human body that essentially care about iodine. They absorb it to make hormone.
So if you introduce radioactive iodine,
The thyroid cells, including any lingering cancer cells, gobble it up. They don't know it's radioactive. They bring it inside the cell, and the radiation destroys them from the inside out.
Trojan horse.
Exactly.
But you have to prep the body for this, right? You can't just swallow a pill on a Tuesday.
It's a logistical challenge. First, you need to be sure there's no other iodine competing for attention. So the patient goes on a strict low iodine diet for a few weeks. No seafood, no dairy, no red dye.
And no CT scan.
That's a huge one. CT contrast dye is loaded with iodine. If a patient gets a CT scan with contrast, their body is flooded with iodine for months.
The cancer cells will be full.
And they won't eat the radioactive pill. So a routine scan can delay cancer treatment by 2 months.
That is a massive detail for patients to know. Imagine delaying your cancer treatment because of a routine ER visit scan.
It happens. The other part of the prep is making the cells hungry. We need TSH thyroid stimulating hormone to be high. TSH screams at thyroid cells to wake up and work.
Got it.
So we essentially starve the body of thyroid hormone for a while, or give injections of recombinant TSH to make sure any leftover cancer cells are desperate for that radioactive iodine.
So we've cut it out, we burn the leftovers, now we suppress. This is the lifelong maintenance phase.
Correct. We put the patient on levothyroxine, which is standard thyroid hormone replacement. But we give them a slightly higher dose than normal.
Wow.
We are playing a mind game with the pituitary gland. The pituitary makes TSH to stimulate the thyroid. If we flood the body with thyroid hormone, the pituitary says, oh, we have plenty, and stops making TSH.
And since TSH acts like fertilizer for thyroid cancer cells.
Exactly. No TSH means no fertilizer. We keep the TSH level suppressed to near zero so that if there's one microscopic sleeper cell left somewhere, it never gets the signal to wake up and grow.
It's amazing how strategic this is. It's not just kill the cancer, it's manipulate the body's feedback loops to keep it dormant.
It's very elegant physiology.
Finally, how do we know it worked? Is there a test?
We have a perfect biomarker called thyroglobulin. It's a protein made only by thyroid cells.
Oh.
If a patient has had their thyroid removed and ablated, their body should have zero thyroid cells.
Which means zero thyroglobulin.
Right, so we monitor that blood level. If it's zero, great. If it starts creeping up 6 months or 5 years later, it's a biochemical alarm bell. It means cells are growing back somewhere, often long before we can see them on a scan.
And that's when the hunt begins again.
That's when we go back to ultrasound or iodine scans to find the recurrence.
This has been such a comprehensive tour. We've gone from the scare of the nodule to the microscopic orphan eyes all the way to the Trojan horse treatment.
It's a complex disease, but the takeaway really should be one of hope.
It seems like the differentiation is the key. Because these cancer cells still act somewhat like normal cells, we can trick them.
We can use their hunger for iodine against them. We can use their reliance on TSH against them. That gives us leverage we just don't have with other wilder cancers like anaplastic or lung cancer.
So if you feel a lump, get it checked. The odds are in your favor, but you have to catch it.
Absolutely. The silent threat is only a threat if you ignore it.
You know, before we wrap up, I keep coming back to that iodine connection. It's a lingering thought for me. We tend to view cancer as this random genetic lightning strike. But here we have a direct link to something as mundane as table salt.
It connects the micro to the macro.
It really does. It suggests that our pantry choices, whether we use sea salt, which often lacks iodine or processed foods, or good old iodized salt, might be subtly shifting the type of cancer our biology selects for.
It's a reminder that we aren't just living in our environment, we are chemically shaped by it.
Biology and environment are impossibly separate.
We really are.
That's it for this deep dive into the butterfly gland. Thanks for listening, and we'll catch you in the next one.